Before I begin my talk, I must acknowledge the W.B. Saunders Company for permission to use material from a paper of mine which is about to appear in Comprehensive Psychiatry. If I could have the first slide. Hermeneutics is the art and science of interpretation, especially the interpretation of texts. The term is derived from the Greek god Hermes in his character as tutelary deity of speech and writing. The goal of hermeneutic reasoning is the elucidation of meaning. It is characteristic of such reasoning that the interpretation made depends to some extent on premises held by the interpreter. Clinicians using different premises may therefore discover different meanings in the same case history. Although the strengths and weaknesses of the hermeneutic method in psychiatry are well described, they are not widely known. As a result, hermeneutic reasoning can be used in an uncritical way, its weaknesses overlooked and its strengths exaggerated. At present, uncritical use of this method threatens the care of certain patients and the integrity of their families. The patients are among those with pseudo-seizures, a behavior that simulates epilepsy. Although it is generally agreed that the behavior is enacted to obtain or perpetuate the sick role, some psychiatrists have proposed that pseudo-seizures have a more basic and recondite function, to express symbolically an aspect of the patient's sexual experience. The best known proposal of this type was made by Sigmund Freud. Freud initially believed that hysterical symptoms resulted from childhood sexual abuse, but he eventually adopted a different premise for understanding these complaints. And I quote here from Freud, "Influenced by Charcot's view of the traumatic origin of hysteria, one was readily inclined to accept as true and etiologically significant the statements made by patients in which they ascribed their symptoms to passive sexual experiences in the first years of childhood. To put it bluntly, to seduction. When this etiology broke down under the weight of its own improbability and contradiction in definitely ascertainable circumstances, the result at first was helpless bewilderment. At last came the reflection that, after all, one had no right to despair because one has been deceived in one's expectations. One must revise those expectations. If hysterical subjects trace back their symptoms to traumas that are fictitious, then the new fact which emerges is precisely that they create such scenes in fantasy. And this psychical reality requires to be taken into account alongside practical reality. Based on this change in premise, Freud believed that when one carries out the psychoanalysis of a patient with pseudo-seizures, one soon becomes convinced that these attacks are nothing else but fantasies translated into the motor sphere, projected onto motility, and portrayed in pantomime. Freud held that these unconscious fantasies were masturbatory in nature. Investigation of the childhood history of hysterical patients shows that the hysterical attack is designed to take the place of an autoerotic satisfaction previously practiced and since given up. In a great number of cases, this satisfaction, masturbation by contact or by pressure of the thighs or again by movements of the tongue and so on, recurs during the attack itself while the subject's consciousness is deflected. The form of the pseudo-seizure was understood in terms of this premise. Loss of consciousness was derived from the fleeting but unmistakable loss of consciousness which is observable at the climax of every intense sexual satisfaction, including autoerotic ones. Abnormal movements were derived from the reflex mechanism of the act of coition, which we see coming into manifest operation when an unrestrained surrender is made to sexual activity. Already in ancient times, coition was described as a minor epilepsy. We might alter this and say that a convulsive hysterical attack is an equivalent of coition. Less common aspects of pseudoseizures could also be understood as having an erotic meaning. The involuntary passing of urine is certainly not to be regarded as incompatible with a diagnosis of a hysterical attack. It is merely repeating the infantile form of a violent pollution. Moreover, biting the tongue may also be met with in undoubted cases of hysteria. It is no more inconsistent with hysteria than it is with lovemaking. Freud was uncritical about this hermeneutic approach to the hidden origin of hysterical complaints and was therefore quite confident in its application. Anyone who studies hysteria soon finds his interest turned away from the symptoms to the fantasies from which they proceed. The technique of psychoanalysis enables us in the first place to infer from the symptoms what those unconscious fantasies are, and then to make them conscious to the patient. This method of psychoanalytic investigation, which leads from the conspicuous symptoms to the hidden unconscious fantasies, tells us everything that can be known about the sexuality of psychoneurotics. In recent years, there has been a return to Freud's initial premise of sexual abuse in the genesis of pseudoseizures. Among the reasons for renewed interest in this relationship are a number of case descriptions in which patients with pseudoseizures report having been raped, the linking of sexual abuse to altered states of consciousness in dissociative and multiple personality disorders, and the controversial claim by Jeffrey Mason that Freud revised his original views on the cause of hysteria not because they were inaccurate, but because they led to his rejection by members of the Viennese medical community. In the same way that Freud deduced childhood masturbatory fantasies from the occurrence and form of pseudoseizures, there is a danger that some clinicians will deduce childhood sexual abuse. Here I do not refer to those cases in which rape is confirmed, especially in close temporal relationship to the onset of pseudoseizures, but rather to the belief that childhood sexual abuse, now repressed or dissociated, must have occurred because the patient has pseudoseizures. Several psychiatrists have recently connected the form of pseudoseizures in certain patients with behavior that might be expected as a response to sexual abuse. Thus, Gene Goodwin suggested that the violent movements of a rape victim's pseudoseizures, and here I quote, seem more intelligible when related to resisting and responding to a sexual attack. And that's close quote. And Elizabeth Bowman proposed that the motor activity seen in pseudoseizures can express, among other things, and again I quote, rage, fist shaking, fear, immobilization and trembling, and sexual activity, thrashing and thrusting, close quote. Here the phenomena that Freud attributed to pleasurable fantasies are, from a different premise, attributed to terrifying assaults. What is portrayed in pantomime is not masturbation, but rape. Although this line of reasoning is less well developed than Freud's, it has been extended to the context of somatization disorder, an illness in which pseudoseizures may be observed. Somatization disorder is diagnosed on the basis of multiple medically unexplained complaints. Eckhard Othmer and Sherilyn D'Souza sought to discover which of 37 such complaints best distinguished groups of patients who did and did not meet full diagnostic criteria for somatization disorder. 7 symptoms, shortness of breath, dysmenorrhea or painful menses, burning in sex organs, lump in throat, amnesia, vomiting, painful extremities, contributed to the optimal separation of the groups and were used as a basis of a screening test for the disorder. To help remember these symptoms, the investigators suggested the following mnemonic, taken from the initial letters of each complaint. Somatization disorder besets ladies and vexes physicians. Gene Goodwin, starting with the premise of sexual abuse as a hidden cause of hysterical illness, read this symptom list in a hermeneutic way. I'm quoting here from Dr. Goodwin. The screening criteria for Briquet syndrome are 7 symptoms selected as statistical predictors of multiple somatic symptoms. One way to order and remember these 7 symptoms is to recall what happens during a rape. The child's arms and legs are immobilized by holding or tying down, leading to pain in the extremities. The crushing weight of an adult body leads to shortness of breath. Oral insertion leads to trouble swallowing and gagging and vomiting. Genital and anal insertion leads to burning and pain, both of which may be triggered by menstrual discomfort. When memories of the sexual abuse become disconnected by amnesia from the bodily sensations, the persisting isolated somatic symptoms can be misinterpreted by the victim and physicians as a mysterious and puzzling set of multiple unexplained somatic symptoms. Given the nature of hermeneutic reasoning in psychiatry, there is little doubt that a different set of complaints could also have been linked to sexual abuse. Once a premise is established, unconscious defense mechanisms are invoked, and symbolic meanings are assigned, the hermeneutic approach can be made to yield the same interpretation time and time again. Hermeneutic reasoning not only permits any symptom to be linked to sexual abuse, it also permits sexual abuse to be linked to any symptom. Although such uncritical use of this method is by no means universal, it occurs all too frequently. Because my purpose here is to caution, I will not review the many strengths of hermeneutic reasoning, nor will I discuss its shortcomings, save one that follows. As before, I will use Freud's writings to illustrate my point, both because his views are cogently expressed and because his confident, uncritical use of the hermeneutic method established a dangerous precedent. Freud believed not only that psychoanalysis could tell us everything that can be known about the sexuality of psychoneurotics, but also that it could reveal the hidden determinants of almost any behavior. Even such apparently innocent acts as slips of the tongue, Freud said, are not so insignificant as people, by a sort of conspiracy of silence, are ready to suppose. They always have a meaning. And it turns out that once again, they give expression to impulses and intentions which have to be kept back and hidden from one's own consciousness, or that they are actually derived from the same repressed, wishful impulses and complexes which we have already come to know as the creators of symptoms and the constructors of dreams. A man's most intimate secrets are, as a rule, betrayed by their help. For Freud, the meaning hidden in slips of the tongue could be interpreted from the assumptions of psychoanalysis, and claims by a speaker to have made a simple error might be easily dismissed. In order to explain a slip of the tongue, for instance, we find ourselves obliged to assume that the intention to make a particular remark was present in the subject. We infer it with certainty from the interference with his remark which has occurred, but the intention did not put itself through and was thus unconscious. If, when we subsequently put it before the speaker, he recognizes it as one familiar to him, then it was only temporarily unconscious to him. But if he repudiates it as something foreign to him, then it was permanently unconscious. This last sentence is familiar to students of English history as an example of Morton's fork. John Morton, a minister to Henry VII, arranged matters in such a way that no person deemed wealthy could avoid lending money to the king. Those who lived ostentatiously were forced to contribute because they could obviously afford to do so. Those who lived simply were forced to contribute because they must be saving their money. Whatever the circumstances, Morton's premise that all must pay was never abandoned. In order for the hermeneutic method to work, in order for it to help psychiatrists understand the meaningful themes that inform behavior, some premise is necessary. Among the assumptions used for this purpose are Freud's of sexuality, Alfred Adler's of inferiority, Harry Stack Sullivan's of insecurity. When several premises are entertained in the process of gathering clinical material, the interpretation that results can be manifold, subtle, and specific to the patient. Unfortunately, as judged by psychoanalytic factionalism over which premise should be paramount, a broad-minded stance is difficult to achieve. Like others who use hermeneutic reasoning, psychiatrists may find commitment to a single premise attractive. If that commitment is an uncritical one, if the premise is never abandoned, the essence of every interpretation will be known in advance, and important aspects of individual cases will be ignored. When the cost of misinterpretation is high, as in questions of sexual abuse, uncritical commitment to a single premise can be dangerous. For the patient who denies having been abused may be caught with her family in Morton's Fork. If hermeneutic reasoning about sexual abuse and pseudo-seizures is used uncritically, important questions about this potential association might not be asked. What, for example, is the evidence for a linkage between sexual abuse and pseudo-seizures? As seen in this slide, derived from recent medical literature, if there is an association, it is a non-specific one. Among phenomena other than pseudo-seizures that have been linked to sexual abuse are agoraphobia, borderline personality disorder, bruxism, that's grinding one's teeth, depression, drug abuse, eating disorders, factitious disorder, hallucinations, headache, inability to complete military basic training, multiple personality disorder, musculoskeletal pain, pelvic pain, post-traumatic stress disorder, premenstrual syndrome, pseudocyesis or false pregnancy, suicide attempts, and vocal cord dysfunction. For each of these proposed sequelae, and especially for the long-term ones, a host of methodological problems must be confronted, including verification of the abuse and proof that a causal relationship exists between remote events and current behavior. Although sexual abuse is not specifically associated with pseudo-seizures, is it possible that pseudo-seizures are specifically associated with sexual abuse? Examination of the evidence suggests, to the contrary, that pseudo-seizures occur in conjunction with a variety of phenomena. In one recent investigation, for example, patients with pseudo-seizures were found to have epilepsy, malingering, abnormal brain imaging studies, bereavement, and delirium. The association of pseudo-seizures with concurrent epilepsy is especially strong and can be documented with considerable confidence. Like other behaviors of clinical interest, for example, self-injury, pseudo-seizures have multiple risk factors. Sexual abuse may be especially important in certain patients, but it cannot be held responsible for pseudo-seizures in general. If there is a relationship between sexual abuse and pseudo-seizures, it could be expressed in the occurrence and the form of the behavior. A relationship to occurrence seems more likely, especially when the interval between the abuse and the behavior is short. In the cases reported by Meyer-Gross, for example, it seems probable that the onset of pseudo-seizures in 3 adolescent females was related to rapes within the preceding year by a father or father surrogate. Because young women are at greatest risk for both pseudo-seizures and rape, an association is more likely in this group than any other. But such an association should be investigated, not presumed. As Venkat Ramani notes, it appears that among pseudo-seizure patients, a history of sexual abuse is most often encountered in adolescent girls. In a few cases, a direct cause and effect relationship may be justifiably assumed. But in the majority of patients, the clinical significance of incest and sexual abuse remains uncertain. For this reason, a comprehensive psychosocial assessment should be made in every case, avoiding a narrow focus on sexual history alone. A comprehensive psychiatric assessment in patients with pseudo-seizures is not limited to a sexual history, but it does include one. For it would be as unrealistic to presume that pseudo-seizures are never related to sexual abuse as it would be to presume that they always are. When a patient reports abuse that cannot be independently confirmed, it seems best to believe the patient and conduct treatment accordingly. When abuse is denied, it also seems best to believe the patient and focus on other issues. Certain patients can be easily influenced and may therefore assent to the notion of repressed abuse when subjected to what Ramani calls overzealous interrogation. Although in individual cases there is a relationship between sexual abuse and the occurrence of pseudo-seizures, a relationship between sexual abuse and the form of pseudo-seizures is less likely. The text of symptoms can always be read for its symbolic significance, as Freud did with other hysterical complaints such as pseudo-blindness and pseudo-paralysis. Still, it should be obvious that what pseudo-seizures portray in pantomime are genuine seizures, just as pseudo-blindness portrays genuine blindness and pseudo-paralysis genuine paralysis. As I will propose in a moment, the first goal of these simulations is to obtain the sick role, or if the patient is already entitled to that role, for example because of epilepsy, to perpetuate or augment its benefits. The form of the behavior is largely determined by the patient's familiarity with the disorder simulated, and the more skillful the simulation, the more readily the sick role will be granted or sustained. The use of a familiar disorder as the template for simulation has long been known, especially in individuals with pseudo-seizures. At the Salpêtrière Hospital in the late 19th century, for example, when patients with hysterical illnesses were housed with those who had epilepsy, the seizures of the epileptics remained unchanged in frequency and severity, but the hysterics were greatly affected by their constant exposure to epileptic patients. Because of their neurotic tendency to mimic, especially the young hysterics began to imitate every phase of epileptic seizures, the tonic and the clonic convulsions, the subsequent hallucinations, and finally Charcot's bizarre postures. Nowadays, the epilepsy simulated is more often the patient's own or that of a family member. In Alec Roy's study of 9 patients with pseudo-seizures and epilepsy, the form of the pseudo-seizures resembled the form of the epilepsy. Patients with grand mal attacks had convulsive spells, while those with complex partial seizures had psychomotor phenomena. It is less likely that the form of pseudo-seizures reveals hidden sexual abuse than it does some knowledge of epilepsy and a desire to obtain a particular type of sick role, the neurological rather than the psychiatric. For certain people, in certain circumstances, the benefits of the sick role are very attractive, and even patients with epilepsy may, and here I quote from Harold Mirsky and Neil Burek, learn the pattern of their attacks, and when it is convenient to solve a conflict by this technique, they may use their knowledge of organic fits in order to develop hysterical ones. Close quote. The sick role is a protected status that confers certain rights and relieves certain burdens. People who seek to augment or obtain the benefits of the sick role through pseudo-seizures usually do so because other ways of dealing with distressing events seem unattractive or futile. The first goal of pseudo-seizures is therefore to occupy a position that is both safe and camouflaged. Once that goal has been accomplished, the necessity of dealing directly with the underlying issue, a deteriorating relationship, an unwanted responsibility, sexual or other abuse, can be avoided, even as the patient signals his need for help. Such reasoning is, of course, hermeneutic in nature, and begins with the premise that a desire for the sick role is the final common pathway for all of the risk factors associated with pseudo-seizures. This premise is less dangerous than that of sexual abuse because it proposes only that an underlying issue is to be discovered, rather than stating in advance what that issue is. As a laudable concern with sexual abuse prompts a search for ever more subtle signs of its occurrence, psychiatrists and others should remember that hermeneutic reasoning can obscure as well as illuminate, and that even Freud was seduced by its power. Thank you.